Hi, welcome, folks. This is Joint Justice Oversight Committee. It is September 9th, and we do have a full agenda today, full agenda this morning in particular. We're going to be starting with just having a broad discussion, I think, of healthcare within our correctional system. I know for House members, we have heard some of this, and I know some of the senators have also heard some of this, but it'd be well worth really spending some time talking with representatives from WellPath, which is Dr. Uliger, as well as Tivia Aviva, I can never pronounce your first name, who is with the Department of Corrections and the Executive Director of the Health Wellness Division. I think it's really important for us to have an understanding of DOC's role as well as the role of WellPath. WellPath is our healthcare provider. The state contracts out with WellPath. It's about a 3-year contract. And I just would encourage the committee to ask as many questions to understand how healthcare is delivered within our correctional facility, as well as the pressures that WellPath may be experiencing, as well as DOC. So if both of you could come on up, great. And also, before you begin, if you could just introduce yourself.
Thanks for having us. I'm Aviva Teva. I'm the Executive Director of Health, Wellness, and Engagement for DOC.
So Jim Uliger, I'm a family physician and addiction medicine physician, practiced in Vermont since 2007, mostly in community medicine for the last nearly 2 years in the corrections environment.
You've been in that role for 2 years.
Yeah, I started in January of 24 as an addiction specialist, and then that July, so just a little over a year in the medical director role.
So are you employed by the department or are you employed by WellPath?
I'm employed by WellPath. Thanks for making that clarification.
To be clear, so maybe you could just start talking about the contract in general, what the process is, where we are in terms of how long we've been with WellPath, when it's up for renewal, and also the price would be helpful too.
Certainly. So we could start on the next slide, I think, to that. So DOC puts out an RFP for a vendor to provide medical services in our system. Currently, WellPath is 2 years through an initial 3-year contract. The previous medical services vendor was Vital Core. So Vermont, the state has the option to extend by a couple years, but on the initial 3-year contract, they're 2 years into the 3-year period. These are some details we wanted to share about how that contract is structured. So first, going over some monitoring, and sorry, the cost of the contract is about $40 million a year currently. There is extensive monitoring of the services provided by WellPath. There's constant reporting and tracking, and we are engaged with WellPath frequently on dozens of health metrics about the system and the services that they're providing. There are robust monthly data reports that DOC receives. We have quarterly quality control meetings with every facility, as well as with the regional office. So kind of similar to DOC in some respects. DOC has our facilities, and then we have a central office. Similarly, WellPath has site leadership at every facility. Dr. Uliger could describe that further, as well as a regional office that kind of manages across the sites. We also have weekly clinical review meetings with both kind of clinical experts on DOC's team and with clinical leadership from the regional office. We have weekly contract management meetings with the regional office leadership, and we have a very thorough critical incident review process. So those are kind of the technical ways that we work together, but just to give you a picture, we're communicating with WellPath all the time, every day, and really working together day to day in a really integrated manner. So We work for different entities, but in terms of the day-to-day management of our health services system, we're working together very closely all the time. In terms of the kind of financial structure of the contract, some characteristics that are helpful to understand. If WellPath spends less than the budget that we have for the year, they return the unspent funds to DOC. So they really have, as a company, no incentive to provide less care because they would not take the difference home as a company. If they spend more than the budget, they pay the first 3% over. DOC pays the next 3% over. And if they spend more than 6% over the annual budget, then it's in our contract that we need to negotiate. So at that point, we would really try to figure out and understand, why and have that conversation about who is really responsible. They also have payment incentives for certain performance metrics, which are performance indicators reflecting the care that they're providing that we have agreed, if they reach certain thresholds above and beyond, they can be paid for that. And that total, if they were to receive all of them all the time, is up to 3% of the contract value. The state also has the ability to withhold liquidated damages. So if we determine that as a contractor, they're not meeting the expectations and the requirements of the contract, and we have to do work because of work they didn't do or the services that they're providing, we can withhold liquidated damages instead of paying them. And then finally, they receive a 10% administrative fee. So that is sort of the profit margin for the company of the services that they provide to us. Everything else in that $40 million budget is for the care that they're providing, everything from the staff to off-site specialty appointments. So those are some of the really kind of high-level summarized details, but just to give you a sense of some of what kind of governs that relationship that the state has with WellPath.
Are there questions in terms of this part?
Just a clarifying question, is the administrative fee on top of the 40 million or is that within that?
That's within it.
Okay, thank you.
And I rounded at the 40 million.
Yeah.
Yeah, it's within it.
And that 40 million is per year.
Mm-hmm.
Wendy and then Topper.
Just generally, thank you for being here. I would be interested in knowing more about the monitoring and actually seeing some of those reports. And the beauty of this committee is that we have the medical folks with us, because usually it's just the corrections representatives and senators. But I'm sure there are some things that are going better and worse. So I think it's really important to know some of that and see how it mixes with what I'm hearing from constituents. Like I'm hearing a lot of issues with dental care from all different places. So, and I see you're going to talk about that perhaps, but that is one thing I'd really like to more information on.
If it's in the reports that we have here, then that's okay. I'm really interested in what happens quarterly when you have these meetings. And I'd like to know, ask the senator that just said, what's happening? And if something's going wrong, how is it being corrected? And then on another report after that, we see that it's been corrected.
Yeah, we could certainly provide more information. Just a quick response to what happens at the quarterly meetings, and Dr. Uliger could add to this later as well. A lot of the process is I won't say governed by, but kind of aligned with NCCHC standards, which are the National Mission on Correctional Healthcare, which are very regimented guidelines for correctional healthcare. And for the state of Vermont, we're always trying to exceed those. Those are kind of the floor as opposed to the ceiling for us and in the quality of care we're providing, but we do have to meet them, and WellPath has to do that to maintain that accreditation, which is really important and part of their contract. And so in the quarterly meetings, among other things, we're always have an eye towards that particular set of standards for correctional healthcare. In addition, WellPath has a very regimented CQI. What is CQI? Quality control?
Continuous quality improvement.
That one, continuous quality improvement structure and process. And so they're looking at different metrics every quarter, and then they do re-studies. So if they study something, they audit it and they don't meet the kind of expected mark, they'll put in place certain practices to try to adjust it. Again, Dr. Yurliger can speak to it in much more detail, that then they re-study it to make sure that that metric actually changed.
Okay, if I could just ask.
Sure.
A year ago.
Yeah.
There was a problem with the individual that's incarcerated coming from the building, the facility.
Yeah.
Into the public setting. And sometimes they didn't have the prescriptions they were supposed to have, et cetera, et cetera.
Yeah.
Has that been taken care of?
Yes, and actually, we're hoping to share some of that with you today because we're
Keep quiet.
actively working on it. No, it's a great question and something that we're paying a lot of attention to.
We did a lot of work on that not this past session, the session before.
Yeah.
In upgrading our statutes to be very, very clear that when someone reenters the community, that they reenter with medication in hand for a number of days and a prescription at the local pharmacy. And it also pertained to, I'm going to call it the MET, medically assisted program, because we have a lot of folks incarcerated who are on the MAT program, and I'd like to get into that too. Did you have anything?
I'm gonna wait. I'm gonna hear the report and I'll ask my questions afterwards. I do have some questions. You probably won't do many of them.
So Dr. Whoops.
Go ahead.
Well, I was just going to turn it over to Dr. Yurliger.
Sure, and I think this isn't in our presentation, but I think it makes sense to give a snapshot of, Aviva did a great job of explaining kind of how what the DOC interaction with WellPath is. And there's can be some mystery around this veil of this like kind of national company and what is this? And I just wanted to explain why as a physician, and I do consider myself a physician first, and I'm working at WellPath because I wanted to do the work at DOC, what it's like to have a company like WellPath. And I have no stake in making this clear, but having the resources, I'll even back up further. The medicine that we're practicing in corrections is some of the hardest medicine that I've ever practiced. People are sicker, not just physically. The incidence of disease is much higher. The people are more vulnerable, not only because they're behind bars, but because they've not had care for a long time. And mental health and addiction health is probably the biggest single indicator of how sick people are. It's very challenging to practice, and we're held to a community standard without necessarily having community resources. And I see my providers struggling with that all of the time. And that's okay. We're happy to have a community standard, but it's difficult, and I can give specific examples. So with that backdrop, having a national company with expertise in the field, I wouldn't have been able to come on as a clinician in our community into an environment where I'm now a leader in our facilities around correctional healthcare without that level of expertise to draw on. So we have operations, we have medical weekly. I sit with I'm going to do it after this meeting. I sit with medical directors from all the other states where we have contracts. How are you solving this problem? I was able to, I'm sure ICE will come up. We're trying to navigate issues with ICE. I was able to speak with our medical director from New Mexico, who had some very helpful things to say about that. So I want to start with having that resource has been indispensable. In terms of how we take care of people, I want to go to the next. Are you driving, boss? Yes. So I think a lot of you are familiar with this, but what it looks like when people come in, they have they have an initial health assessment in booking by a member of our nursing staff. That's to see to screen for certain conditions, mental and physical, but also to make sure they're healthy enough to come into our facility. And we've had some recently that weren't, and the nurses have done some great jobs. Some of them have been admitted outside the state because their care was so complex. And they were able to identify that as a nurse alone in a facility in the middle of Vermont. That was amazing. They do great work. Within the initial health assessment that you see within 7 days of booking, that's the first provider visit. It doesn't mean we wait for 7 days to provide the medication. As a matter of fact, that nursing calls us as soon as that booking screening is completed and reviews all the medications. We're required by law to continue all of those medications unless there's some reason we can't. Obviously, if somebody's on an opiate for pain control and they're over narcotized, we're not going to continue their opiate, right? So if there's a medical indication not to continue that. Until they're seen by the clinician. And then we can adjust the medications if necessary. And often that occurs within before 7 days. People were asking about some of the data parameters that we are measured on. That is one of them. We see them within 7 days. And I don't have the update. We typically do a good job on that one, though I don't know the exact numbers. The mental health and substance use assessment also happens within 7 days. And a lot of times, so those are actually, we have an interesting, the way that mental health, substance use health, and physical health has been parceled out through the history of American healthcare is unique. And it's similarly unique in our setting. So our our medical providers are doing the substance use care, and our behavioral health providers are doing mental health. So if somebody screens positive on any of those things at intake about depression, anxiety, bipolar psychosis, they're seeing mental health, and they're seeing somatic providers for any substance use health. I would tell you that a lot of the screenings after the initial booking are positive, because in booking, we're screening them for use disorders. Well, what's your substance use? And there's a corrections officer. And one of the limitations of our facility, we're try very hard to have privacy. But even if we do have privacy, the person has to have confidence in that privacy. So they often don't share with us at the intake. And then the number of people that actually screen positive within the next several days is very small compared to that initial. And then there's a dental examination within 30 days. Maintaining dentists and dental care is an absolute challenge. We can talk more about that. After this initial intake and screening process, there is we see people with chronic disease every quarterly. Honestly, whether they need it or not, we're supposed to see them. I get some grief from my providers. Well, this person in the community with hypertension, we would see them once a year. It's, yes, but they're not in the community. And so when we say we're held to a community standard, I like to say we need to be held to higher than a community standard, because our folks are sicker than folks in the community. So that's a snapshot.
So just to be clear, when someone comes into the facility and they're in booking, and you do that initial screening within 4 hours of the booking, that is for detainees as well as those who are sentenced, correct?
Yeah, so that's unique. We have both detained and sentenced folks. People say, sometimes the security staff will refer to somebody as offender. We actually don't know that some of them are offenders because they haven't been convicted of anything yet. And yes, everybody gets that.
So if someone's arrested on a Friday and they're not arraigned, they're arrested in order to be held.
Yes.
They come in on Friday evening and they don't go into their court for an arraignment until Monday. You go through these steps.
Yes.
And they could be released on Monday.
Yes.
You have a lot of churn coming in. Because I forgot what the number is of folks who come through your system on a yearly basis. And a lot of that is short-term detainees. So I just want to put that out there. So folks, this isn't just folks who are sentenced.
How do you ensure that someone who comes in on that Friday who may have a chronic illness and requires medication has that medication?
Yeah. The nurses have a medication confirmation process that they go through. That's not the name. What am I forgetting? Verification. Thank you. There's a medication verification process that they go through that includes calling the pharmacy, includes Vermont prescription monitoring system, which those are most of the medicines that they're going to feel bad with that they don't have right away. So there's a process, and then they call us and review that. And then there are questions sometimes. Sometimes we need more information, and that can do some temporizing until we can get the full information.
I know that was an issue a few years ago with an individual who then died as a result of not having medication. It sounds like you are trying to correct that issue.
I think that goes, I don't have data in front of me, but I don't, do we do 100% of the things right at the time? No, but I'm not aware that is an issue specifically in our contract right now.
Would it help to do the numbers?
Yes, I'm going to back up just a little bit. Thanks. I was just curious, how long has the state been under contract with WellPath now?
2 years.
2 years. And how often, if any, does it happen where they don't spend the allocations that's given to them evidently up front, or how often does it happen that they actually exceed it by 3%? I realize it's only been 2 years, but.
Yeah, so I believe they've been under the last 2 years, and they've also been in the process of transitioning to the new contract and had staffing challenges, and staffing has improved. And that's one big place that they've spent less than budgeted. If they're not staffed at 100% of the contract, there will be savings there. Although sometimes that comes out in other places like temporary staffing that they use to make up for it. But the last 2 years, it's been slightly under budget.
Okay, and a quick follow-up. I realize this may not be doable, but geographically, do you have the information, as for instance, Northwest Correctional Facility versus Springfield, as to majority of substance abuse issue, mental health issue, whatever that may be? I realize that it's because someone, say, maybe in St. Albans, they may not be from the northern part of the state, and vice versa here. Is that something that you do track as far as?
I don't know if we have system. I mean, I'm sure there's somewhere some specific. It's not something that I keep track of on a regular basis. I can tell you Springfield, for example, is where our infirmary is. It's where our specialized psych ward is. It's where our ward for people with long-term care needs is. So the sickest people mentally and physically go to Springfield, but wherever they came from, that's where they end up. Our women's facility in Northwest do most of the ICE care. And that's that churn. That's a lot of and so they've been hit disproportionately by that. So I don't know whatever's behind your question. That's a little bit of some of what's going on.
I'm just curious, and maybe you'll get into this, so apologize if I'm just kind of leaping ahead, but the slide we kind of went past. On the ER visits, it looks like that's on a trajectory that is going higher, and so I'm presuming you all have to pay for that out of your contract. And through 2025 year to date, I mean, it looks like you're on track to surpass 2024 again. And so what are the causes for the ER visits? What's the, what are people presenting with that is, I get the message that people are sicker than the general population. What is, is it, I don't know what it is. Can you elaborate?
And it's a fascinating and unfortunate thing just to witness the variety of pathologies that I've never seen in my career, practicing for a long time. But long enough. And I haven't seen a lot of these things. So it's not one thing other than the underlying mental health, substance use disorder, and the things that go with it. But we have people with innumerable, and I'm trying to be careful because a lot of them are so specific. I'd like to name them, but I would literally be identifying the individuals if I name the diagnosis. Mm-hmm. So it's kind of hard. Mm-hmm. But we have people with various transplants, end organ damage, various things that haven't gotten care. Diabetes hasn't been cared for years. And then they have various acceptances of how much care they'll accept for those. And so we've had a number of folks go to the ER, in training, we always called it acute presentation of chronic disease. Like, this has been a problem for years, and now all of a sudden it's a crisis tonight. Mm-hmm. And that's driving ER usage. One thing that's driving emergency department usage right now is the average daily population, which is very high right now. It's
the what population?
The average daily population.
Over 16.
Yeah, it's over. And I think on a slide, it said, about
more people, more ER visits.
Absolutely. This has not, so things we're doing to address this. We are We have an on-call service called Zenova where people can have a telehealth visit if a nurse is worried about somebody at night. They can have a telehealth visit, and sometimes when you can lay eyes on somebody, once when I got a call, I sent somebody to the ED, and afterwards I'm like, I should have used Zenova. It was like 2 a.m. I was thinking about, I should have used Zenova because they could have done an EKG on that person and potentially saved an ER visit. So that's something we're doing. We're encouraging the use of Zenova. So if people have acute issues, we're actually really asking people, please do not call our on-call provider that's handling no, you can't. You can always get an on-call provider, right? And then if they don't get the on-call provider, they get me, right? There's a very purposeful level of services. However, please call Zenova first without calling the provider, because it's likely that they may be able to save that ED visit because they can actually see the person.
So what I'm hearing you say, it's a variety of different things, and and do you see, other than Springfield, where I just understood you to say that's where kind of the sickest of the folks are, do you see any trends in terms of correctional facility and use of ERs? Is there more ER usage in St. Albans than there is in Chittenden County than there is in?
I would have to compare that to the census. It would have to be a per capita census. And I'm just looking, we report on that every Friday with the DOC. And I can tell you, certainly Southern has the most, but they also are one of the larger facilities. And I can tell you qualitatively, I'm not looking at the numbers, but Northern has a few more people than Southern, but Southern sends a lot more. It's because their people are sicker.
Right, yeah, okay.
So that makes total
All right,
sense.
thank you.
Isaac?
Chair, I was just going to point out very quickly that, we're on track, like what it said, for about 20% over last year. So we well over 880 visits if we continue at this pace. And to Dr. Mueller's point, corrections is housing, some of the sickest Vermonters, some of the most vulnerable Vermonters. And that has, these numbers have a direct implication on our staffing, as you can imagine. Because if these folks are admitted, in particular, they will need round-the-clock staffing, and so that's why we're ready that hospital too. But this adds pressure onto our staffing issues that we have.
Our security staffing, right? Yes.
Mm-hmm.
So when someone is transported to the ER in an ambulance, 2 correctional officers go with the person. So that correctional officer is coming offline. I mean, they're online in a different place, but they're coming out of a unit. And then if the person is admitted, is it 1 or 2 officers stay with them?
It depends, but usually that's why we created the hospital coverage team about a year or 2 ago to deal with this exact issue. So we weren't pulling field staff in to do this hospital coverage because obviously the facilities do not have the staff to pull those folks out. So I think with the COD, Central Operations Division team, the hospital coverage team, it's about, I think it's 1 person, and they need round the clock security staffing to the hospital.
At the room.
Yeah, and I would say on average, and I'm looking at Dr. Kiva, we have a handful of folks who are hospitalized at any one time. Usually 4 or 5 folks, sometimes as high as
2 to 4, yeah.
2 to 4,
Yeah, and then like the other Friday, it was 0, and the care manager and I scratched our heads. We're making sure our email was working.
But sometimes it's 12. I mean,
Yeah, it can be way more than that.
Yeah.
And I think this is, and if it's not an appropriate place to bring it up, I think one of the challenges, we're going to list challenges. One of them is really tertiary care access. Because we've had to send a number of folks outside of state for their tertiary care. So for Claire, just to level set, secondary care would be you have pneumonia at the Springfield facility and you go to Springfield Hospital, get intravenous antibiotics for a few days, then you come back. Then the tertiary care would be, and then you go into renal failure and need to go to UVM or Dartmouth.
State.
Or base, yes, and that's the problem. So we're sending people to Bay State and Albany out of state. So I'm working with UVM in their algorithm because they have a regional care algorithm, which if somebody's in Springfield in the community, they say, okay, well, it's really more appropriate for you to go to Bay State, for example, so we could take somebody from St. Albans. I'm talking about not incarcerated individuals, just generally speaking. But I explained to them that we're having to send officers out of state. And so I'm working with them to try and keep some of these people in state. So somebody from Springfield would go in a different place in our algorithm. But access to that specialty level hospital care is a huge problem that we're dealing with.
So if you're, I understand what you just said, particularly if the person has to go down to Massachusetts or New York, Albany.
Yes.
But living along the eastern border, a lot of our tertiary healthcare is Dartmouth.
Yes.
So would that impact what you're looking at, so you don't send folks, correctional officers, out of state to be with the person? Is that going to impact folks going to Dartmouth? Because that's where our care is.
No, that's in-state in my mind, right? Right, no, I would love, people get great care at Dartmouth. I've been very pleased with that. That's good.
So for the ER visits, are you seeing them more with folks who are detainees than folks who are sentenced? Or is it pretty equally spread out against both? Because we have about 500 folks who are detained. And we have 1,200, 1,000, about 1,000 folks, or not even 1,000, more than are sentenced.
These guys over the numbers.
I don't know. Well, and I'm going to let Aviva answer that, but I asked her if I could start because most of the time I don't know. And there's no real medical way without going into the correctional database for us to know. And we don't go in there because unless we have a business to know why somebody's in, we don't need to know why somebody's there. So often I don't know.
That was the same point I was going to make, and I think it underscores a point you made earlier, Chair, which is that we're providing the same health services to somebody regardless of their legal status, regardless of the reason that they're being detained. And that is evidenced by the fact that in the electronic health record used by WellPath, they literally don't know whether someone is detained or sentenced. Now, we're working on changing that because for release planning, medication and other release planning, it's going to be really helpful for them to know. So that's in motion right now. But I think it does make the point very clearly that the medical staff are not making decisions about someone's medical care with that information in front of them.
So the MMI asks for 90 days prior to release, Medicaid. So that's not blind.
Yeah, so that's a great question. And that project is one of the reasons why we're making that particular change, so that in the electronic health record, that sentence status will be there, because to your point, someone won't be eligible unless they're post adjudication.
So before I go to Teresa, I just also want to make clear, folks that are not familiar with the DOC world. When someone becomes incarcerated, even though they may have Medicaid or they may have private insurance, that is no longer used when a person's incarcerated. That's all federal decisions. So when a person's incarcerated, any health insurance coverage they have is lost. So all the medical care, prescriptions, mental health, substance use disorder that's provided while they're incarcerated is done through our state budget. Except if someone is hospitalized, then that's a little different. But I want folks to understand health insurance is not providing the payments for folks who are incarcerated. And that's for sentenced and detained folks.
So it's not a question per se for the witnesses, it's just a thought, and I don't really know how I feel about this, but I actually appreciate the sort of ethics behind, like, I don't know if it's a detainee or somebody who's going to be with us for a while. But then sort of the fiscal side of me pops in and says, if we're not really going to have a long-term impact on somebody's healthcare, why would we go through all of these steps for someone who is going to be with us 48 hours?
Because they could have a medical event that they die.
Yeah, that's true.
Under our state custody, even though they're a detainee and are there 2 days, they're under state custody. And we'd be liable. We'd be sued.
It's also potentially an opportunity to have something screened and identified that then they could receive care for after they're with us. So it can be kind of a positive intervention directly as well.
And we do see the average length of a detainee is probably 4 days, 3 days. But and we'll get into this later on in testimony with the department update along with Judge Zoning, of those detainees. What is the length of stay for some of them? Some of them are there 2 or 3 years before they go to trial. So you've got to balance that as well. Because the bulk of our detainee numbers, the 500, whatever, they're going to be there for quite a while. Because a lot of them are held without bail, or they're held with a high amount of bail, which we'll get into. So there's so many layers to this that it's sometimes hard to change.
Yeah. Well, what does seem to be moving forward is more of a seamless healthcare world for folks who are detained or incarcerated. And that's an improvement, I think, that at least I start to see. I notice in the data that the information that you brought us, that the concerns are that the infirmary is a little tiny place and not a good place to provide care. And I don't, only when I've been to a couple of them, but Springfield comes to mind. And I know you've got dialysis there. But so the infrastructure improvements probably need to be made. Something to think about institutionally. Then, but the question that I have really is regarding the improvements that are being made for care. Ultimately, the goal is to release someone who is healthier than when they came in, perhaps. How are you able to measure that? Are you able to measure the effect of healthcare on the overall improvement of the incarcerated individual?
Yeah.
And have you thought about that, and what kind of data would we collect to demonstrate the effect of trauma-informed care on the incarcerated individual? I would say patient, but it is a patient.
Yeah, oh, a patient, that's what I
Yeah,
said,
that's
patient. So that's a beautiful question, and I love that it's coming up, and to be fair, it's a complex question, so I haven't.
Slightly.
Yeah, no, well, but no, that doesn't mean it's totally worth it. We have had so much improvements to make in the fundamentals of how care has delivered. The fact that my head can even entertain that question right now is a sign that we've kind of made some progress, and there's plenty left to make, I'll be clear. But I think that's, and complicating that question. So I don't have an answer for you, but I'm
Didn't
real.
expect one, but
Yeah.
I mean, ultimately, the goal is that someone's walking out of the prison with, who has some future. And
Yes,
that includes the healthcare future, and what effect, if any, has healthcare had on that individual's ability to work in society?
absolutely. And two reflections I'll want on that. Generally speaking, incarceration is not a therapeutic environment. And not because of anything we're doing, but it's not. But why couldn't it be, right? Can it be for some people? And the other tension that I'm feeling, and wisdom is always in tension, I think, is we're trying to make it as easy as possible for people to take good care of themselves. And if we're getting them ready for life on the outside, we're helping them get ready to take care of themselves. And so helping people by not creating false barriers, while at the same time coaching them through advocating for themselves and caring for themselves. As we're redesigning this whole machine, and that's what you were referring to, that this, I've been very transparent with my company with everything. If we're not making progress in that redesign, I'm not going to do it anymore. Because we're in such a place just getting somebody into the office and being seen and getting good care and going back. That has required a lot of fixing. And I'm seeing progress, which is why I'm still in the seat. And then we're going to be able to answer bigger questions or ask bigger questions like that as that.
I just have one, this is a very specific question. So there was a specialized nursing facility that opened up in Bennington a year or so ago. Are you seeing any increased access to long-term skilled nursing care with that?
Yeah, I don't know from that facility specifically,
Yep,
that was
that's
Brenda's,
Mission Care.
but yeah. Oh, Mission Care. Oh, yes. Yes.
Yeah.
Yes, the answer is.
Okay, that's good.
So I just want to
Paying a lot
highlight,
of money for it.
Someone just.
I
Yes.
just want to highlight two important data points. In terms of those folks who are in our system, incarcerated, 1,200 of them on average per month have a chronic illness. And we're incarcerating about 1,600 folks total. 1,200 with chronic illness. And prescriptions that are dispensed per month is around 7,000 prescriptions. And I've heard in the past that on average, a person who's incarcerated could have up to 10 prescriptions per day. Is that about accurate? Just
Yes, so average is 5 or 6, and so then we have some with 0 and some with 10, and that's not uncommon in the community where somebody's suffering the burden of chronic disease.
so that kind of goes into your question, are they coming out a little healthier? It's hard to judge that, but just to put those numbers out there so people can see how much healthcare is being provided within our facilities, whether we agree with it or not, or it's done on a timely manner or not. There's a lot happening within our facilities. They're a healthcare provider.
But it's not, it may not be that they reduce the number of prescriptions around, rather their ability to take control of accessing what they need. That's what we're talking
Might be that
about.
they're on more.
Yeah, so it's more behavior, there could be some behavior modification going on.
Yes.
It's all part of the same question.
So let's keep going.
I've lost track of where we are, which is fine.
That's all right. I think we've been peppering you with questions.
Okay, towns, yeah, why don't we do challenges and initiatives? We talked about a lot of the challenges, so we don't need to, we have nobody, I don't know a physician, any of my colleagues who loves their EHR. But this is honestly the most difficult one I've ever worked with, and and it's outdated, and we have an upgrade plan, so that's happening.
EHR is,
Oh, I'm sorry, thank you, the electronic health record. Yes, it's extraordinarily cumbersome, and hopefully relief is on the way. We have infrastructure issues.
Is that a well path?
No.
That's a state of Vermont.
The state holds the contract separately.
Yeah. We significantly increased average daily population. We talked about access to tertiary hospital care. We talked about access to post-acute care. So that's, you leave the hospital and you're not ready to go home because you still need care, but you don't need hospital level care. A lot of the skilled nursing facilities that offer post-acute care in Vermont, frankly, won't take our patients. And that's a real challenge of finding that post-acute care. An aging population with an inflexible infrastructure, we talked about that. Infirmary space, this is a crisis. I have to put huge asterisks around this. We have 9 infirmary beds in Southern. We have 3 at Northern, but the 3 are kind of in a fishbowl. It's not a place where you can live. It's a place where you can get prep for your colonoscopy or get antibiotics for a couple of days while you're recovering. It's not a place where you can live. Many times those 9 infirmary beds at Southern are taken up with long-term care folks with dementia or whatever reason that can't be in a general population. And then they're not available for our people coming back from the hospital who need acute nursing care for wounds, et cetera. This is a big deal. It's gonna get worse, not better. So I have to stress that.
It's also why the transitions to mission care have been so meaningful. Is those are
Yes.
people who were living full-time in the infirmary who are now not taking up those beds anymore because they're in the nursing.
And what work has been done with Dale, the Department of Disabilities, Aging and Independent Living, to try to open up other nursing? Because, we have empty nursing beds. And rehab beds should be available for people, who have a knee replacement or whatever and need to have rehab in a nursing facility. What kind of work has DOC and WellPath been doing with Dale to to get them to push nursing facilities a little bit more?
So I know that we've been focused on the long-term care piece and building additional partnerships. Union House is an example that's taken multiple people from us. I'm less familiar with the kind of, post-procedure support.
Yeah, and usually those people
Temporary.
often come back to the facility. So I don't know as much about, or we haven't seen as much with the post-hospitalization care. Usually we provide the post-hospitalization care. There's been some situations where we've run into issues where we can't provide the level of, and then the hospital says, but they don't belong here anymore. And I say, yes, but we don't have this. There's a person who required 3 people to move them. Like, I don't have 3 nurses at night. I can't accept this person. Hospital didn't like that. Nobody else would take them.
Yeah, well, probably a nursing facility doesn't have 3 people to move them either at night. Okay, thank you. I want to encourage continued discussions with Dale, across AHS because, frankly, we pay a lot of money to nursing facilities and they've, I would like to see them be more active in assisting folks with dementia care, with other long-term care needs without us having to pay premium for that care when the presenting individual isn't any different than the other person with dementia.
That was actually one of the neatest meetings that we had in our committee, was having all of the commissioners and representatives from the different departments and the agency talking about this very issue. It's long-term care, mental health, substance use disorder, so on. So that is really important to stay connected. And I will be talking with the secretary about that again. I think it's important. Right.
That's a weekly line item in our clinical report. And I forget Brenda's actual role, the nurse on the DOC side.
She facilitates a lot of the partnerships, working closely with Dale and also with the homes.
But we have, I say every Friday, Brenda, who do you got for Dale and Mission Care? What's going on? And so we run that list every week. What do you need? Is there anything you need from us to make that person?
Yeah, I'm just thinking about expanding beyond mission care, frankly, into other locales, not everybody should be trucked off to Bennington to get long-term care.
I think we've made some real progress just in kind of familiarity and awareness so that those nursing homes know what we provide in our facilities and who we've been talking about benefiting from being placed there instead.
So I know this was an issue in the past. I don't know if it still is now. But one of the issues with housing some of our folks who were sentenced in a nursing home could jeopardize their Medicaid reimbursement, particularly if it was a person who was convicted of a sex offense. I don't know if that's still the case, but I know in testimony in the past, that has been a real concern from nursing home operators, that it could jeopardize their Medicaid. I don't know if that's the case now.
Doesn't sound real to me,
But the person would be considered incarcerated if they were on furlough or even on parole. And how does that impact the funding mechanism for the whole nursing home? That was a piece that has come to light 5 years ago, that came to light many times. And
we have a new Medicaid director, so we'll.
Right, but it could be federal, it could be CMS.
It could be. It could be.
So you mean if they're on choices for care, is that what you mean? If they're on choices for care, which would fund the,
And these people are, so I think they are receiving that Medicaid funding.
Maybe discharge them from corrections and then they're just like anybody else in the community.
I don't disagree with that, but that has been, I think, one of the stumbling blocks out there. So I just want to put that on the table, because we feel differently, but it could be CMS that's driving some of this. The other thing too, I just quickly want to put on the table in terms of the infirmary space and the number of beds. So when folks hear of a facility being built and talking about bed counts, those infirmary beds are part of that bed count. And I think it's really important for us as policymakers to understand that differentiation, because people get hung up on the number of beds, thinking they're all cells where you house someone long-term, and that's not the case when you're dealing with bed counts. So if you want to build facilities with more infirmary space and more beds, that's gonna impact your bed count. So I just want to put that on the table so people can start understanding that. So let's move on here.
Yeah, I can move through this, and I suspect there might be some questions about this in particular, but we already touched on release planning and obtaining medications on release. We've developed a process for that, and we've had good progress. We have 100% uptake in 3 of our facilities. One of our facilities is about 2/3 on that process, and the challenge with that particular facility is getting enough notice for providers to do the proper review. So it's not a we don't feel like it. It's like trying to figure out how to get the providers to be able to do the chart review in time because the person's on the way out the door.
Provider being the outside provider?
Or the inside provider. Our provider getting, and this has happened to me, that, oh, so-and-so is leaving in 20 minutes and you're with a patient. But so I have to
Is
like,
that person a detainee?
sometimes not, sometimes they're sentenced folks and we find out so if we have a week's notice, we should totally be able to deliver on meds in hand. Sometimes we do not. And that, and when I say we have 3 facilities functioning at 100% in our process, we do have, even the law says, meds in hand. Sometimes we do not have enough notice to provide meds in hand because it takes a day. So we will do a local prescription for that. So we do have to make that allowance because it's important that they have some kind of medication. But sometimes we don't have enough notice.
3 facilities are 100%.
It is Marble Valley, Northeast, and Northwest. We're still waiting for data from Southern and Chittenden, and we'll see how they're doing. It doesn't mean they're not doing it. It's just there is some leadership stability at Southern that I'm very pleased has resolved, and I think we'll have some.
Leadership within WellPath or leadership within the facility?
The WellPath.
I have a couple questions.
Yeah.
So going back to the kind of the billing and the cost and the money piece a little bit, what codes are you using? Are they Medicare, Medicaid, for billing?
For the 1115 waiver reentry initiative,
Huh?
for the new initiative.
Or WellPath generally? So,
None.
Currently, WellPath does not bill Medicaid for services.
no, not billing Medicaid, but what codes are you using to bill the state? So if you're to understand that you're going over or under 3%, so when you treat a patient, what is the treatment code that you're using or set of codes that you're using?
Yes,
So-
I feel like that. Go ahead.
The pharmacy that we use is Diamond Pharmacy. It's a subcontract that WellPath holds. And so when a provider puts in an order for medication for somebody, whether it's medication at hand on release or while they're just with us, Diamond Pharmacy fills that order, and then that cost is part of the expenses by WellPath.
So beyond the medication, it's a mental health counseling session. What code is used there? What's the?
We don't use CPT or A&M codes like we would community. There is some reporting that's not my wheelhouse, but it's about there's like a provider hours that are available, and I forget that there's some
Yeah.
productive bill rate or something that we use.
There's a face-to-face versus admin metric for something,
There's a
but
time,
one of
yeah.
the reasons why the Medicaid reentry initiative is such a massive lift is because currently none of that is part of our services, and so we'll need to shift to incorporate it.
And then
The billing center is done at a per member per month.
Got it. Okay, so it's PM.
2,300, something like that per individual, and that's what's driving our costs higher, is we have more people in our system, which means a higher PMPM than we.
Yeah.
That's helpful. Thank you.
Sorry, I didn't realize you were asking that. It's all averaged into that rate.
Okay, so in terms of, so we passed a law last year that said that mental health, a person in residential facilities seeking mental health care could have extended number of hours for treatment. We don't follow that. No, okay.
Well, we wouldn't limit it in any
Yeah.
way deliberately in our system anyway.
we might limit it by resources available,
Right,
just
yeah.
what we can do. So
But some people's care is going to cost a lot more than others depending on their need. And hopefully the average rate sort of captures the actual average. But if it doesn't, then we would see that in the budget difference at the end of the year.
Parker?
Thank you. Where is this Diamond? Is that what it's called? Diamond Pharmacy?
It's from Western Pennsylvania,
West Pennsylvania?
Western Pennsylvania.
And how long does it take
You can
to
have medicine by tomorrow,
have it by the next day?
typically. And if there's something that we
Okay.
need, on an emergent basis, we get local fills. There is that always has significant cost. If we need something unusual from a local pharmacy, it costs a lot more. You get it a lot less
Does
expensive.
does it cost more to get a prescription in one day from Pennsylvania?
Not that I'm aware of, no. I mean, I don't know all the details of the contract, but I've been impressed and surprised by our Diamond's ability to get things at us at a good cost. But not being the money person, but I've been impressed.
Cool. I was just wondering, because we have a pharmacy in the hospital here in Vermont. I don't know whether I don't know how long it takes to get a prescription on there.
Yeah, hospital pharmacies, we've had to work with them for unusual medicines and specialty pharmacies, and it's, and I don't know the reasons on their end, because there are often reasons, good or bad. And it's complicated to work with, sometimes, the hospital pharmacy.
So I want to finish up because we have to shift gears here, but can you briefly talk about the MAT policies and what you're seeing?
Yeah, so this has been an ongoing since I joined in January of 2024. It took about 8 months to rewrite and modernize our map, modernized from 3 to 5 years ago, but to really bring it to the next level of being congruent with national guidelines. So we've done a lot in the last year. We've normalized our med lines. So it used to be you got buprenorphine in its own med line. Now you get it in the regular med line. That's really important for a couple of reasons. Number one, it identified you as somebody with that medical diagnosis if you went to the med line just for that medication. And it was also a place where people got in trouble, so they didn't want to go to the med line, so it drove some diversion. Now also much higher risk is methadone, because it's very hard to overdose on buprenorphine, methadone much less so. And so now we have fewer people in that special med line. Methadone is still in the special med line. And so we can watch them closer. That alone was a huge undertaking. We converted the community standard is a combination of buprenorphine and naloxone. In the facilities, we were just using buprenorphine plain. We converted everybody who is medically indicated, not everybody, but almost everybody, to the dual product buprenorphine naloxone. That was a giant undertaking. We saw every patient in our program in 2 days, was seen with a brief visit and because that's what we're required to do to explain that. We are now that we've just hired an MAT specialist nurse practitioner who's going to handle all the most complicated folks. So it's now no longer a choice. Like if you come on with us as a provider, you're going to be a provider. That was something people got to choose before. That's just care now. We all do that. However, to help people understand or to do that, to give them the resources, we're constructing a little hub and spoke model within the facility. And are people familiar with the hub and spoke model? Basically, most people are nodding yes. So 5% of your patients take 90% of your energy sometimes in terms of how we manage them. And so if we could take the most complicated 5%, which may change over time, off of each provider at the facility and have them see our buprenorphine specialist, people can spend more, of their energy on the day-to-day. So that's going to help us with handling aberrant use. Aberrant use, some people would call diversion. But if somebody's having trouble with diversion, they can see our bup specialist. She can see them more often than we can. We're also trying to get to a therapeutic dose in a timely way. There are a lot of people, therapeutic dose is 16 milligrams, sometimes 24. There are people sitting at 2 and 4 milligrams, not acceptable. We're working on that. often people would sit with withdrawal symptoms for a long time over the weekend, having diarrhea on the floor. It was terrible. I mean, absolutely terrible. We're still working on trying, instead of just giving you symptomatic medications like anti-nausea medicine, we're actually starting bupe at night on the weekends. And we're not 100% there, but we're working on that. And the hub and spoke model. So was there anything else you were?
How many folks are in the MAT program?
I think it's a little bit, well,
Yeah.
Isaac, I can ballpark it, but you know numbers.
Depends how you count, but about 60% of people in custody.
Yeah. I think about half are on buprenorphine. So about 800 right now are on buprenorphine plus or minus, and there's a modest number of people on methadone.
Is there any update in current statute in terms of our MAT procedures? Or what's driven by law? Because last session, we were trying to bring it a little bit more in line with what was actual practice. The bill didn't go anywhere, but do we need to update the statute to make sure it's reflecting what you folks are doing?
To be honest with you, the biggest, why I'd let Isaac to speak to, but the thing that would help the most, I think, is not in our power, or your power, is to just make methadone more accessible, and that's of course a federal thing. But that's a challenge. Isaac, I didn't mean to cut you off.
Well, I think we had this discussion at length in the committee chair, and I feel very confident in the internal changes that we've made as a department, and then we've pushed through in our departmental policies. I think sometimes when we start to open that Pandora's box of legislation, as we saw in committee, we go places we might not want to go, and I feel very confident in the direction we're going right now.
The statute, you also do MAT for detainees as well.
Absolutely.
So thank you. I just want to make sure that you'll get back to us on the dental situation, because I've just heard terrible stories from multiple places. And then also on the evaluation of the progress, because you said you have robust methods. So I'd just like to see some of those.
One of the initiatives on here is the backlogs. And so we've seen a really dramatic decrease in the number of patients who are waiting for appointments, among other things, but that's one.
Among the dental patient?
It includes
Or just
dental, but
general?
there's less of
Okay.
an improvement there than
For
general.
sick call, that when I came on, there was a sick call backlog in the hundreds at Southern. But we only have 300 people there. Like, how could you have a backlog of hundreds? It's in the single digits now.
Okay.
Uh,
Yeah, that's the
Single
kind of,
digits
Mhm.
between like 0 and, we'll see it bump up and bump down, but there was a culture of like, oh, it's just a 300. That's what it said. It's not okay. But
To be fair, those weren't all symptomatic sick calls. There's a lot of other communication with medical
Yes.
that's counted in sick calls, people asking for medical records, or an example I hear a lot is requesting a journal for mental health journaling. All of that gets included in the
Yes.
numbers, but we should still know exactly what our symptomatic sick call numbers are, and they should be lower.
absolutely no. And I'm sorry, Aviva, I didn't. So a lot of it was administrative, like I need a letter for I need a this. And that's not sick call, that's something else. And so changing that process was essential to take care of sick people.
Shows other.
I'll wait till I hear back
Okay.
about the dental. I have lots.
Do we have time to discuss this, or is this something you want to
Let's do it quickly.
briefly? So our immigration holds have caused a lot of concern for our providers, particularly at Northwest and our women's facility at Chittenden. Language barriers are a challenge. We do have translation services, of course, but you never get as much as thorough a history that way. Patients typically have trouble engaging health services because they're asking us to talk to a lawyer or family. They haven't talked to family or anything. We don't always get as much information as we would like. That's not necessarily different than any other setting, but it is a little bit challenging sometimes. A lot of times we'll be told, so length of stay, so we'll be told at 11 at night that we need to have 10 detainees ready for transport at 4 in the morning. And that's very challenging to have that all taken care of. And there's some subjective feeling from some of our providers that their medical opinion when requested, isn't always honored, particularly for fitness of transport. That's anecdote. That's not but I just wanted to let you know what we're dealing with there. And I think the biggest thing is it's causing a lot of moral concern from our providers that they're involved in this effort. And so I just wanted to pass that along. That's something I've heard from them.
So how does that impact our contract with WellPath? I know we get X amount of dollars for each ICE person that's held, to cover the medical costs as well.
The medical costs are included in that agreement.
Is it, when do we get paid? Before or after?
I believe that it's similar to the PMPM in that the average health costs are included in the rate that
Just
no matter.
when an individual comes in, that,
Those funds flow directly to the general fund, not the music budget.
The funds from
Any reimbursement from immigration, same with markets, well, any federal contract.
those to the general fund.
Because they're using firewall.
However, the WellPath contract is based on an average daily population number. And so as our population grows, regardless of who is in our custody, that will have a direct impact on our healthcare costs.
Just a comment, I appreciate you saying that the providers are, they're just having difficulty morally dealing with that. But I would just ask that you let them know, at least I appreciate their work very much. And especially because it's more difficult. It's what they're doing matters. So thank them.
I will absolutely pass that along, and I should amend my comment too, because it's the providers I talk to most, but it's the whole care team. It's not just the providers, but thank you.
So are you aware at all if we've renewed our contract with ICE or not? I mean, probably not the appropriate entity to ask, but it expires. So,
It's a great question for the powers that be. I don't know the typical, maybe that was shared with it.
it goes through the governor's office, is that right? Yeah.
Do we have a copy of the contract?
which contract?
The one you just talked about?
ICE, but with the ICE contract, we'll have to talk to the fifth floor, because they're the ones that would have negotiated that, not DOC.
And just to clarify for the committee, there are two controlling documents. There's an MOU with Customs and Border Protection and US Border Patrol. It's one vehicle. And then the vehicle that ICE operates off of is our contract with Marshals, the United States Marshal Service. And that has a rider on it that allows both DOD and ICE, but in this case, notably ICE, to operate using that contract vehicle. So really, the agreement is with the US Marshal Service to send it through that ICE. But just to be clear about the legal mechanisms at play.
So if we want to pursue this, then we would need to schedule time at our next meeting, but it would be through the governor's office. So they're the ones who are in the driver's seat, and they're the ones who would negotiate, it's not DOC. It's not the department.
Is the contract a public document?
I would assume so,
Um,
but you know what assume means.
every government document should be publicly available. That being said, I would refer to the Department of Correction for the most recent version of those contracts. I do not have.
Madam Chair, everyone may not want it, but I'd like to see it.
So let's put that down on a list for our agenda. For our October meeting. Anything else for the medical piece? Okay.
Thank you.
I want to thank both of
Thank
you.
you.
Are you still here or you headed out? Want to check you for 1 second? I'm sure you know what it is. And we will transition with Isaac to, as well as Joe Zone, go through some of the data overview. And I know it's going to get into folks who are in the system.
Yes.
Okay, so we'll move on to Isaac. Do you, Judge Donay, you want to come up after, or would you like to be here together? It's up to you two, whatever works best for
I
us.
think if the judge wants to join me in the hot seat,
Okay, here now.
that'd be great.
We will.
Okay. So we have the updates that you provided for us, so why don't we just begin with your introduction to, and then we'll listen.
Okay,
Thank you for being very vocal.
share my screen here. Okay. So for the record, Isaac Dano, I'm the policy director at the Department of Corrections.
And I'm Judge Tom Zone, Chief Superior Judge.
Great. So I think the committee asked for a brief data update. So I just wanted to run through these numbers, and apologies, they might be a little bit small on the screen. We should have printed copies. So just wanted to look at population numbers over the past few years. And as we talked about in this morning's testimony, these numbers are very important in that they have implications for our facility staffing. They have implications for the cost of healthcare delivery within correctional facilities across the state. So just an important trend to keep an eye on. And of course, the Department of Corrections, it's a no refusal policy. And so obviously the judiciary, along with state's attorneys, law enforcement, has a major impact on the numbers that you see here. So this is looking at just annual averages of our sentenced male population. So you can see that is dipped down in 2023, but is continuing to rise. Our detained male population in particular is rising. So this latest number, 513 is our 2025 average. That's up from an average of 338 just a few years ago.
What percentage of those who are detained are actually become sentenced? Do we have that data?
Great question. I don't have that
Okay, all right,
information there.
but you can get
Essentially.
it. Not easy to get.
No, it's probably not, but it really is.
And so this is just looking at those two trends together. I always like to show this chart in committee. It should look familiar. This is looking at our male correctional bed capacity. So if you look at the month of September, we are now over that 150% general population bed capacity. This is the primary reason we have 128 male individuals housed out of state in Tallahatchie, Mississippi, the Port Civic facility there. We do not have enough space in our correctional facilities. We do not have enough space for programming. We do not have enough space for the individuals who are in the custody of the commissioner.
A follow-up question on that. With the detention population increasing, are we having to send more people down to Mississippi to make room for detainees?
The number of folks who are in Mississippi has stayed relatively stable in the kind of between 115 and 130 number for several years now. That number may have to be adjusted upward if these trends continue. But there's also a process by which we clear individuals to go to that facility. And it's a relatively small subset of individuals because they have to be sentenced folks. So they're not going back and forth to court. They need to have medical clearances. We want to make sure they're relatively stable and longer sentences.
Okay.
So the short answer is not at this moment, but that may move in the future. Looking at the female population, this number is also rising. Again, these are averages, but the average has continued to accelerate. And I just want to be very clear. Today, we have 174 individuals housed at CRCF, the women's facility in South Burlington. That is among the highest I have seen in the that is the highest I've seen in my time at the department. And I think in the last decade or so, the actual capacity of that facility is 177 beds. So we are nearing the capacity of our women's facility. Any questions on that?
So my question will be why, but maybe that's later on for the two of you to talk about.
And then moving on to bail data. I want to be very clear, our bail information is all point in time. So it's very difficult for us to pull this longitudinally. And one reason for that is we take the information that we get from the court on the lodging documents from the court. And a correctional officer in our booking area will input that directly into our vendor management system, our data system at the department. They'll literally kind of fat finger it in to our system. And it's really meant for an individual at an individual level. So when someone makes bail, and presents that cash, because we take cash or a bail bondsman, will facilitate a bond, but it's really just to facilitate the making of bail. So it's really meant for an individual level, which is why the department is always, I think, hesitant to go too far down this road. But I will present you with our point in time extract as of this morning, I think around 5 a.m. So you can see here the number of folks that this applies to. This is the columns here: under $1,000 of bail, 42, in the thousands, 91, tens of thousands, 78, hundreds of thousands, 15 individuals. Parole violation detainees, I can let maybe the judge can also speak to this more, but 48 individuals. So those are folks kind of in a special category who are awaiting their hearings with the parole board. Held without bail is the majority of folks. That's 310, giving you 584 as of this morning.
I'm sorry, I missed some of this. Do you have, I know this is more your bailiwick and you were more.
Bailiwick?
That was a
Yeah, I do have, so I guess my questions are more, what this data is going and hopefully can dig into, and I don't know if we'll dig into it right now. So for instance, I understand it's point in time. Do we have like a point in time from the past year or so that we can compare this point of time to? I mean, we asked for this data before, and so we can see if we can see how much this has changed as far as those held without bail versus held on bail, because we did change some bail laws last biennium. And another question that I have, which this is not showing, and it's a question of whether we can understand that with additional looking into the data for future meeting, is how long are people being held, who are being held without bail? How long are people, you've said there's average like 3 days for detainees. That's a lot of churn there. Is that the same for those held without bail? Probably not. Just understanding like how long are people being held without bail? And also just particularly with the women's prison, seeing that increase is, what are the underlying charges that we're seeing more individuals being held? Those are all questions that are answered on here. And I don't know if you can shed some light, Judge Zolli, on some of those.
The sheet that is up there now that Isaac has put up, the backup to that sheet answers the question you asked last. And that is, you can go onto that sheet and look at each individual and what they're being held on with the charges. So that is something that if you've got this entire, I think it was 119 pages when I got the most recent iteration of it yesterday, but you can tell that information from there. I don't.
That's on the DOC page?
That's a DOC document, yes. DOC, if I want a copy of that in the morning, I'll just send an email over and Jordan Pasha will generally send it back within minutes. He's very, very attentive and very good, but DOC generates that. Another question you asked was, and you mentioned about the last biennium and some bail changes. If you look at this point in time, this is as of 9/9/2025. I went back and found when I had one of these same documents from May 6th of 2024. I don't get one of these every week, but I ask for them occasionally. On May 6th of 2024, The less than 1,000 the number was 23. That's now gone up to 42. The number for 1,000s was 60, which is now 91. The 10,000s was 83, and that's gone down to 78. The 100,000s were 16, that's now 15. And the hold without bail has gone from 270 back then to 310. And so one of the questions that I know Senator Harrison alluded to was, well, why? In order to know why these numbers are changing, you would have to actually go in every one of the 13,488 cases to try to figure it out. But I think it's pretty clear that on July 1st of 2024, there was one statute that took effect, and that was the one that talked about, it amended 13 VSA section 7551. That statute said that if someone was charged with a misdemeanor that was expungible, that the maximum bail, no bail should be imposed, but the maximum bail would be $200. That law changed. And if someone was out on conditions of release or was out on release for pending charges, the $200 limit was eliminated. And so that would have been as of July 1st of 2024. And so when you look at the rise in the number of less than 1,000 and the 1,000s, I think that it may very well, again, I can't say for sure, but I think it logically may flow from the fact that when the judges are being asked to assess the facts before them and the potential for someone to flee and not appear, that without that limit, a judge is determining that bail is appropriate to make sure that that person is at hearings. And it may be in an amount that is greater than $200.
So that makes some sense, but we don't know for sure whether this reflects that what we hear is that we're having more violent crimes in Vermont, certainly homicides, and that may reflect the held without bail. And we may also be seeing cultural change in the judges, maybe more willing to impose bail, given what's happening in public and the concern about public safety.
I want to be very clear about that. That's something that people will say often is that, well, the judges they have concerns or they're responding to the public concerns. Certainly judges hear and are not immune to understanding what the concerns are and taking them into account. But when a judge makes a decision for someone's liberty, they apply the facts to the law without bias, prejudice, or sympathy, or public clamor, or those concerns. So I want to be very clear that some people have said that, well, judges are responding. Judges are addressing the cases before them in a way that is upholding the rule of law. The byproduct of the changes may very well support, because you've mentioned, Chair Lalonde, about the perceived increase in violent crimes. Well, that certainly could be attributed with the additional 40 hold without bail from the numbers in 2024 that I gave. So that's consistent. And then when you see the increase of bail on the low side and you don't see anything in the middle, that certainly may be attributable on that low side to the $200.
I'm glad I asked that question about public sentiment and how that.
Again, the court is not, we understand. We certainly take things into, we consider the facts and the law before us. And we have to, again, without bias, prejudice, sympathy, we have to make the decisions that are based on the law, the rule of law.
And may I also add, Your Honor, with all due respect, they're also not making those decisions with regard to the bed counts within Department of Corrections, whether we have open beds or whether all of our beds are full. And so I think that's a very important note to make.
And that's correct. If a judge believes that an individual is a public safety risk and he or she needs to be held without bail, a judge does not base that decision on, well, what's the bed count look like? The judge makes a decision on the determination of whether does that individual for public safety need to be held without bail. And if they do, the judge orders that. And as Isaac started off, they're open. They have a don't say no policy. 24/7, 365, they're open.
I have one follow-up. So as far as you mentioned that the charges are clear on the underlying very long report, are those added up somewhere, or do I have to go through and look at every one of those charges to figure that out?
We can pull a longer extract. It's essentially like a giant CSV Excel file, which we could pull. I also might want to also bring in, speak of the devil, the crime research group, which I know through this S14. I know they did. There you go. The crime research group, which, could speak, it's like, it's almost like, yes, enter stage right. They could speak to some of this as well through the process of S14 to create the reporting for the state around many of these topics.
So I listened to your numbers from 24 to now. But our population numbers that are being held right now in our facility is more now than it was a year ago. So percentage wise, are those any different? If you looked at the percentage in terms of how many people were incarcerated in May of 24 versus now in 25. As our population has increased, there's more folks now being held. And that's going to reflect a higher number possible.
So when I took my position, one of the things I did, and I will give a shout out to Josh Rutherford at DOC. Before Jordan Pasha, Josh was the one who sent out those numbers. And I contacted him and I said, can I hand something out? Is that okay?
Yeah.
And I said, Josh, what do the numbers look like for the past few years? This is just a chart that I have kept for myself. But I think it really sets out what we're looking at here. We're talking about the numbers and going up. This has a line graph, 2019 so far to 2025. And I think it probably, what's the old expression? A picture is worth 1,000 words. So I'll just ask, any questions? This is point in time. What this generally represents is either the first day of the month, second day of the month, whatever the first day of each month is that I receive the list in the morning for the detainee population. I put it into this chart. And what do we see? We see 2025 is well above everything else, standing up top. And there's been a consistent increase, it appears.
So really the baseline would be 2019, not 2020. 2020 with COVID, it was, but 2019, the light.
Shade of blue.
One of the blues.
It's the one that starts off just below 400.
That is really more of the one to compare now to then would be what I would suggest.
You can see that also, Chair, on this chart in green. I know you're mixing different populations here, but the green is the male detained number, and you can see that at 565. And then I can also pull our numbers for this morning. But this gives you a sense that, sorry, this is not the most visually aesthetically pleasing, but our total detention population is at 667. Our total state detainees is 590.
So state detainees is 590, and then the additional 70 folks are through the federal marshals and ICE.
Mm-hmm. Yes, we have the ICE detainees as of this morning. There are 8 men at Northwest and 8 women at CRCF. I'd say that's roughly about average.
So the federal detainees are mostly not ICE?
They're mostly U.S. Marshals.
U.S. Marshals?
Yes. Those are folks who are facing federal charges in the federal U.S. District Court in Burlington or Rutland.
But they were arrested here in Vermont.
Yeah, so these numbers, are they having an impact on the backlog or the throughput, the processing time of cases?
When you say having an impact,
Well, how does it? Yeah, I mean, I'm trying to see the relationship between what I'm seeing as far as the increasing numbers and, how.
The increase in, if someone is picked up over the weekend, for instance, we know that in our emergency lodging blocks on Monday, it's going to be crowded. So we have remote hearings to address the lodgings at that time. And the fact that we're having the necessity of doing those types of remote hearings, if there's a lot of individuals coming in, well, that might have a judge not be able to attend to something else that afternoon that may have been scheduled, because if you have 20 people as opposed to 5, it may take away your ability, or it may delay what you're working on. So yes, the larger the numbers of detainees coming in, the higher, the more attention it needs by the court. And that certainly brings with it the potential for a judge not to be able to move on to the other matters that may have already been scheduled. When you look at the challenges we face, one of the challenges is if we have more individuals, to try to find the bandwidth to get them to court, whether it's for remote hearings that we have, or the transportation for the sheriffs. I know that's on your agenda this afternoon. But the difficulty the court faces is that we don't transport people to court. The backlog represents people, and people need to be in court to have their cases resolved. They either will be there remotely or they will be there in person. If we have DOC struggling to assist us and provide remote hearings based upon the challenges that they face, and we have the sheriff's department saying they have challenges and they can't transport people, we still have certainly a population of individuals not in jail who we can address those cases. But if we can't bring the people into court, it does impact our ability to reduce these numbers.
Anything else on the detainee and the bail issue?
I just want to understand what you said just about the backlog, because I don't know if when you say it changes these numbers, were you talking about the backlog, or are you talking about the number of folks?
The number of individuals who come into the custody of the Department of Corrections changes on a daily basis.
Okay, so the backlog in the courts, though, has that has caused challenges in different ways. Not just this, but with permitting, and I mean, there's all kinds of things that are impacted by the court. So didn't we increase the number of judges a few years ago? Or is everybody hired? Is all the staff hired?
We still are hiring staff, but we're down one judge. There's the governor has been given the names for individuals. Thank you, Senator Norris and the others on the JMB for your work there for an open Superior Court position.
Okay, so will that help?
It has helped.
So would it have been worse?
Yes.
Okay.
Without the assistance the legislature gave, we would not have been able to make the gains that we've been able to make.
Okay.
Certainly.
We should keep talking about that. It's fine. Okay. Thank you.
Anything else on this? The next piece on our agenda is really short because it's been sort of corrected, but there was an issue percolating out there that if a local police department arrested someone, court was in session Monday through Friday, and there was a court order that the person be held until they are arraigned. What was happening was that the local police department was finding that the facility, correctional facility, was saying to them, well, court's open, so we're not gonna hold them because the court's open. We'll hold them if the court's closed. The police department was saying, but there's a court order, we'll have the person held. So there was some miscommunication, there was something occurring here, and this had been percolating for the last couple of months. It was impacting more one county than other counties. So this has been resolved or clarified in the past few days. So that's why it's still on the agenda. So I suppose we clarify.
Yeah, thank you, Chair. I think you said it well. I mean, it was just a really local incident with one facility, the Springfield facility, and I think some misinterpretation of standard operating procedure that we have agreed upon with the courts. And glad to say it's been resolved.
We don't agree on all the SOPs. Because the way it works is Department of Corrections adopts its standard operating procedures and then says, this is what we're going to do. And we go back and say, well, it doesn't work for us. And we talk. And this is a perfect example. The SOP that came out on July 8th had some changed language that apparently led at least one of the facilities to believe that they wouldn't accept someone with a conditions of release order during court hours. When we found out about that, we contacted DOC and they were responsive. We have regular meetings with DOC, the Defender General and Department of State's attorneys, and they were responsive, and we were given assurance that the problem would be addressed, and that, again, to go back to what Isaac said at the beginning, they're always open. They have don't say no policy, and we understand that has now been addressed.
So it was creating some problems with our state's attorney's office, local police departments as well, because there's no way to hold a person sometimes locally. Anything else?
I do note, if I can, at 2:30, you have Ben scheduled to testify on the post adjudication, an update. I'm the chair of that committee, and I didn't know if you would find it helpful and relieve Ben of any responsibility if I gave you a 2-minute update.
If you're willing right now.
You mind?
Now.
I can do it right now or come back.
And then you don't have to wait until.
The post adjudication reparative work group was charged with a number of aspects of looking at the post adjudication reparative probation. One of the things that we had to do was file a report update in January. We then had to file an update in July. Those updates were filed. We have our next due date is November 15th. The report at that time, which is literally sitting on my computer right now up because I was working on it today, will have recommendations for changes, statutory changes that we're going to be asking the legislature to enact in order to address what we think can make the post-sentence reparative probation work better. And so that will be a timely report.
So the July report does not indicate any of that yet. It's going to be the new updated report.
Yeah, that's correct. The July report just hinted that, yes, we expect to be filing the November report with the recommendations. And one of the statutory requirements was to make a submission of what we want for specific changes, not just to give an overview of these areas, but to say this is the specific statutory change we recommend. And that is what the final report that will be filed before November 15th will include.
Deal with that on our agenda in November, or December, depending on the meeting. Do you still want to give a little bit of a background at 2:30 on this?
Yeah, I can. It's, just to give the committee some familiarity with the concept.
Thank you, Judge.
Thank you. Have a great day.
Great. Thank you, Isaac. So we're going to shift gears a little bit to Zoom. There was when we met, Martin and Ginny and I met with Megan and Ben to set up our schedule for this season. And this is when there was a transition happening in DOC from Commissioner Demo to the new Commissioner Murad. And in the article that came out, I think it was in VT Digger 7 days, I don't remember which. It was an interview with Commissioner Demo as to his tenure as commissioner. And one thing that he mentioned was that there's a lot that's expected of DOC to provide, not just while a person's incarcerated, but particularly when a person's reentering the community. And feeling that DOC can't do all of this, that our community partners really need to step up to the plate and provide services. So there was concern about that was brought up from both Senator Lyons and Representative Long to see if we could have a broad discussion about this. in the committee. The hope was to have former Commissioner Demo come in and explain a little bit more of that. Well, he's moved on. So I know that in the past, we have worked with the Council of State Governments, looking in terms of initiatives that could be put in place to, one of the first justice reinvestments was really looking at the projection of our incarcerated folks and what that would be, and initiatives that should be put in place to bring our population down. And then Justice Reinvestment 2 looked more in depth in terms of what the issues are for folks who are incarcerated. It didn't look so much at population growth as it looked in terms of the system and initiatives that could be put in place when someone does re-enter the community, they are successful and don't come back into corrections. And it was very clear in those justice reinvestment reports that our community partners do need to step up to the plate and help provide some services to folks who re-enter from the incarcerated setting. So we've asked David Demore to come back to us with maybe a summary of what they found in their work with the state over 6 years worth of work that you've done for us. So we have both David Demore and Ellen Llewellyn, I can never pronounce your last name, Ellen, from the Council of State Governments. So I'm not sure if David, you're going first, or Ellen, you're going first.
Ellen will lead us off.
I'll kick us off. Hey, everybody. It's nice to see you all this morning. It's actually been really interesting to revisit some of the original findings we had from working with Vermont going back to around this time, actually in 2019. Justice Reinvestment 2 kicked off in late August of that year, and we sprinted to get to final analyses and findings and recommendations by the end of 2019. And the culmination of that work was the passage of Act 148 in July of 2020. So without belaboring all of the information that we brought before some of you in the room and many of your colleagues a few years ago, the key areas of emphasis, I would say, in our findings were recidivism, right? And just really identifying that I think it was 78% of prison admissions were driven by people being revoked off of some form of community supervision. And that could have been probation, parole, or furlough. And the majority of those were folks coming out of prison onto a furlough status of some kind. They didn't come back into prison for very long, but they were being revoked at very, very high rates. So it was people who were failing in the community that was dominating prison admissions and made up almost half of the prison population in Vermont at that time. And the other key findings that I think are relevant to this discussion today are that when we worked with the Department of Corrections to look at risk assessment data around people who were being supervised in the community and people who were incarcerated, it confirmed that pretty large percentages, particularly people who were incarcerated, were identified as being medium to high risk. And David can speak more to what that means exactly, but typically it tells us that there's just a population of people who have higher risks, higher needs. And a lot of those tend to be driven by mental illness or substance use disorder or the co-occurrence of both, right? We refer to co-occurring disorders, folks who are grappling with serious mental illness and substance use and addiction issues. And so a key area of focus around our recommendations to Vermont a few years ago were really needing to identify ways that people could connect to care and support in the community more reliably and more consistently to ensure that fewer folks were failing on their form of community supervision and ending back up in prison. So I'll hand it over to David. We did all of this work with you in Vermont between 2019 and 2020, and then colleagues of ours helped to implement the new policy changes that came online thanks to Act 148 for a couple of years. And we're obviously working with you all now to look at pretrial supervision and other things. So just to say, some of this is dated for sure. We have not done a really thorough assessment of Vermont's community-based services and care in a minute. But David can speak more to what we've heard in the past and what we've heard a little bit more recently.
Sure. Good morning, folks. David DeMora with the Council of State Governments Justice Center. And, what we found at the time were a couple of things that were difficult. One was sort of the transition to the community, so that even if folks were getting programming within the facility, when they got to the community, that may not have been available for them. And particularly for individuals with significant mental health and substance use needs, that's problematic. And so problematic in the sense of you need that continuity of care. You need to be able to access that care. And so there were sort of two different issues there. One was the issue of, excuse me, whether the care existed at all in a particular part of the state. And the second part of that would be whether people could get in and whether they could get service. Generally speaking, folks who are returning to the community have difficulty accessing services. They may be put on long wait lists. They may not have the ability fiscally to be able to do so in terms of insurance, et cetera. By the way, as you may no doubt know, Vermont has successfully received the 1115 Medicaid waiver, which will in fact give people more resources in terms of accessing care. That may still end up overwhelming what you have available in the community. And there still may be some determinations of what are more profitable types of insurance, if you will, in terms of how people access care. One of the other issues that we saw was sort of a lack of coordination within AHS between the different departments or divisions. And on paper, you have a dream system. You have disability and aging, child and family, economic assistance, housing stability, mental health, substance use, public health, DOC, probation and parole, all under one umbrella. But DOCs remained in many cases very siloed away from that. Not having difficulty, if you will, being integrated into those other programs, into those other services. Ideally, internally, those different agencies could be better integrated to really build a sort of circle of support, if you will, around individuals as they return to the community. And sometimes you hear an argument of, well, why do they deserve that? They did the wrong thing. That's not the issue. The issue is if we want community safety, if we want public safety, and if we don't want to keep sending people back and increasing the incarcerated population, then we need to figure out what the issues are that are causing them to fail. And it's way more complex than they're not nice people or they're bad people. It's way more complex than that. What we see in the population are high levels of people with mental health and substance use needs, one, the other, or both, as Ellen mentioned before. One of the things that we really recommended at one point was making changes in how funding went to the community mental health centers to make sure that these folks had access. You need to relook at your statutes about how you do the funding, because right now, basically, DEMIS is more of a pass-through, if you will, that they don't really control or manage what goes on in terms of the mental health centers. And so part of what holds them up in terms of what they can do is how the statute is written in terms of what their authority is, what their requirements are. And so one of the things that you might want to relook at and rethink is whether or not some of those statutes need to be rewritten, rethought about for this time, for this period in time, and for what the needs in the state are. Because the way that it's currently structured, it doesn't appear to be effectively meeting those needs. Regardless, if those different departments, divisions within AHS could find a way to better integrate what they do, you'll have better outcomes in terms of people that are returning to the community. Ellen mentioned this issue of high risk and need. I just want to make sure everybody knows what that means. High risk doesn't have to do with dangerousness. High risk means that they have more of the factors that are likely to cause them to fail than not. And the need is what needs to be responded to in order to lower those factors or to resolve those factors. So things like substance use is both a high risk and a high need. Things like mental health are high needs. Housing is a need issue. So there's a lot of those need issues. When you combine those things, when you do an assessment, what's called a risk and need assessment, it tells you here are the factors that need to be responded to, and here's how we need to do it. It does not mean dangerousness. And I just want to harp on that for a moment, because a lot of times when we shortcut and we talk about risk assessment, people think that we're talking about like threat risk or those kinds of things. That's not what this is about. What this type of assessment is about, or what are the things that sort of led them into the problem behavior, and what are the things that we need to do to respond to lower that problem behavior. And typically those things involve good mental health, substance use treatment, looking at issues like food insecurity, economic insecurity, educational difficulties, housing issues, if I didn't say that already, in terms of responding to those things. Not everybody needs all those things, but if you had a better way, a more integrated way of these services that are under one umbrella, really thinking about and looking at these individuals as they come out, being able to send them to the right place, that will be better off. I read the article that in terms of Commissioner Demmel's interview, and I couldn't agree with him more. DOCs cannot do everything. First of all, they are really good at certain things. They are not good at other things. It's not their fault. It's like asking me to be good at, 20 different things. I'm not. I'm good at a certain set of things, and I have that training and that skill set. DOC is good at a certain set of things. By default, they have tried to do their best in terms of meeting these other needs, and they work hard at it. But that shouldn't be the case. It shouldn't all be there. It doesn't make any sense. It's frankly fiscally inefficient to do it that way. And the outcomes aren't as good, right? Because they can't possibly do all of those things themselves. A probation officer or a parole officer can be very skilled at a number of things, but not at all of these things. That's why there are different departments. That's why there's different divisions and different specialties. And so we said then, and we say now, that in terms of increasing success, there has to be better integration with the community partners. There has to be a way for the state to interact with those community partners in a way that says, these are the things we expect of you, as opposed to, well, no, there's the fiscal, the funding pass through. That's the end of that. If you want better success, if you want better outcomes, again, suggest you relook at the statute around that and suggest that you really put a focus on how to better integrate the departments or divisions within AHS around their specialties, and how their particular specialty can focus on people that are returning to the community who need that. Again, not everybody needs everything. Some people need very little, but you have a significant population that needs a lot, and that's why they keep coming back. That's why your pretrial detention is increasing, because of the needs of those individuals and what needs and how they need to be responded to more effectively. And one of the best ways to do that is to try to get all the right actors at the table in order to put that plan together. And with that, I'll stop.
So Dave, in your work with the state over the years, has the reluctance from the partners been coming from them in terms of working with previously incarcerated folks who re-enter the community, or is it DOC isn't reaching out to them? How do we get these community partners engaged in working with folks who re-enter the community from an incarcerated setting? Is it coming from them or is it coming from DOC?
There's no one answer to that. What I can tell you is that, and now we're going back a few years to be clear, right? When I was doing this. So I want to be very clear about that. So I don't know what's been happening in the last several months, but when I was going around to the various offices, in the conversations that I had, they were reaching out. They were indeed connecting, and depending on where in the state you were looking, in some places there were very solid relationships and there was movement going on. In other places, those relationships were not so solid regardless. In one office that I was in, the probation officer that I was talking to, she had developed relationships with local landlords and was actually being very successful in that area. In another part of the state, despite their attempts, that wasn't working as well for them. So I don't think it's a one size fits all answer across the state, but generally speaking, I think that DOC has historically been reaching out to these individuals, and then in some cases, out of I guess, for lack of a better way of putting it, out of frustration, feeling that they needed to then try to develop something themselves. But that will overwhelm them. That shouldn't be what their mission is. They really should be counting on community partners and getting community partners to the table. I don't think DOC alone can do that, which is the other reason why I think it's important that the different departments in AHS really help in those areas, pulling those community partners in, and that the legislature, have a very strong opinion and view about the need to have that done and to make sure that there aren't things in statute that are getting in the way of it happening.
But we can change the statutes, but how do we bring these departments or these entities along to do this? And I'm just going to put out an example that when all of this came out, we put money aside from the bed savings for justice reinvestment. We put, I forgot if it was 400,000 that we put aside for the Department of Mental Health to beef up services to help folks with mental health issues that were reentering the community. 2 years later, they still had not expended the money and didn't know what to do with it. But we were very clear what the money needed to be used for. So how do we get our partners engaged here? That's one little example. And I don't know whatever happened to that money, but it was pretty clear what it would be used for. We did that legislatively, and it sat there for 2 years. Ben?
I have several thoughts. I'm just trying to narrow them down into one cogent answer here. One of the things that I would have done with that money, assuming that there is not a statute that keeps me from doing it, is that I would have taken that money and developed specific grants to those different centers to use to provide services to those individuals specifically. If that wasn't done, I think one of two things needs to be figured out. One, if it wasn't done because the department didn't do it, then someone needs to ask them why. Two, if it was in fact that they could not do that because of the way the statute's written, that they couldn't be that specific in saying do this, then revisit that and fix that piece. Because I understand that has been brought up several times in public meetings, the inability to do certain things because of the way that things are written in terms of the law. And Ellen, I think you said you wanted to add something.
Well, I was just going to say, and we are not by any means the experts that you all will want to get more detail on this from, but David mentioned the Medicaid 1115 waiver that Vermont received approval for last year. And I don't know how many of you are familiar with that, but it's from where we sit in criminal justice policy world, it's a game changer. These waivers are incredibly significant. They have, high potential for reshaping exactly what we're talking about, which are connections to care, resources, partnerships at the community level and in jails, not in Vermont, and prisons across the country, or at least in the states that have received these waivers. But anything that has high potential for great change also has potential to fall flat, right? And to not meet the implementation goals. And so it would be really worthwhile, I think, for you all as the legislative leaders responsible and focused on these issues in particular to become more aware or really engaged with how that waiver is being implemented and how partnerships are being developed around it. Because at the most basic level that I could say, not about Vermont specifically, but generally, is that these waivers allow for Medicaid dollars to be used on reentry focused behavioral health support and programming like never before. And so while it's not new Medicaid money for the state now gets to use Medicaid funding in a different way in this world. And that, like I said, from where we sit, is really significant, and a new influx of resources. But to your example, Representative Emmons, just more money doesn't solve the problem, right? So you can have a lot more money, but if you don't have the cooperation and the partnerships necessary to make the money work the way you want it to, it won't. So I would just highlight that. But again, I am not as familiar with Vermont's 1115 waiver or where those efforts sit. And I don't know if Isaac or anyone from DOC is in the room. I don't want to put anyone on the spot because these are very complex documents and plans, but I would just highlight that for you all.
So, thank you for all your comments, that we have listened to this, the work that you have helped us with, and appreciate it very much. Last session, I had all the departments in to my Health and Welfare Committee where we were discussing how to improve the process. And it seems to me that what we need to do is to evaluate where we are legislatively. We need to have some guidance document, legal document, law that will begin to change the tone. You're right, DOC can't do it all, can't do everything. But also have to be willing to allow for others to work within that DOC umbrella to help make it happen. So it's a process, and we will be working on that legislatively. It's one of the things I am having on. And has a question.
Well, just a comment on this exact thing. So Act 40 of 2023 created the Coordinated Justice Reform Advisory Council. That was created and established to establish a unified and collaborative state approach to support state and local community-based programs and services that are consistent with Vermont restorative justice policy. The council is directed to consult with state and local partners to use a data-driven approach that improves public safety, reduces correctional and criminal justice spending, and reinvest savings or redirects funding in strategies that foster assistance or decrease crime, delinquencies, and recidivism. It was set to be repealed in a couple of years, but the council itself felt that it should be repealed sooner, so it was repealed last year. But that being said, I mean, just observing the discussion, there was an entity that at one point was created, I think, to do at least some of the things that are being discussed now. And from my own personal memory, when this was being drafted, debated, and ultimately passed, a lot of the concerns were, well, what are we going to do when justice reinvestment ends? And this was, I think, was supposed to be the next chapter of that. So just some food for thought for the legislators.
That is something we can discuss further and make a recommendation to standing committees that this is an issue that needs to be addressed, and these are the steps that we ask you to look at and lay out what those steps are, if people are interested in doing this. Isaac, and then I'm gonna go to Wendy and then Martin.
Thank you, Chair. I just appreciate Ellen's point about the 1115 waiver, which you heard a little bit about this morning from Aviva, a little bit Dr. Gilbert, and I think we've heard testimony on in this committee and then also in Chair's committee. Happy to dive more into that. It is a significant lift for the department, and it does require very close coordination with the Medicaid policy team, the Secretary's office, as well as with Viva to rebuild MMIS. There's also some expert technical consultants that are helping with that project, but it is significant. To your point earlier, Senator Lyons, we have to figure out how to do coding within our EHR, which isn't set up to do that for Medicaid. So and we're also working very closely with the Vermont Chronic Care Initiative. That's going to be embedded in the facilities to do the care navigation to meet the requirements of the federal waiver. And then all the money that we save from not spending that money using the Medicaid dollars, leveraging that has to be reinvested in the process. Anyway, it gets pretty technical pretty quickly, so I want to make separate space for that. If you all would like to have that conversation, but we're also looking to opioid settlement dollars. We've been using those the last couple of years to facilitate our the turning point centers all across Vermont, which are fully integrated with probation and parole and our correctional facilities. They come in and do peer-to-peer coaching. Senator Lyons, you also asked about research, thinking about continuity of care and success following incarceration. I know that the University of Vermont Justice Research Center is using funding from the National Center of Restorative Justice with the Rutland Turning Point, which really pioneered that model to study the efficacy of that programming. So that's something that I'm sure Professor Epi Crocker could speak more to.
Wendy, and then Mark?
Just generally, I have a question about how with these partners, what percentage of those partners are state partners and what percentage are not within the purview of the state, but I can talk about it or
Well,
find
some of
out.
that, like I'm thinking of our DAs or designated agencies, they're not a state entity, but they receive state dollars.
Okay, right?
And the same thing like with pathways, that's not a state entity, but they receive state dollars. So that would be a funnel, but also you've got a lot of folks who are incarcerated and have families, and the children could be involved in DCF. The family could be involved in DCF. There's a holistic approach there. It's really been, and this has been a struggle that's been ongoing for all my time dealing with corrections. The other departments within the Agency of Human Services do not see DOC clientele as part of their clientele. They see it as DOCs, and that's where the problem exists.
So, but remember that the community services have contractual relationships with each of the departments. So if it's a mental health, a DA serving mental health folks, they have a contractual relationship. It's a matter of maybe putting a grant or RFP out and saying, now we're opening this up more broadly for mental health services or substance use disorder services for those who are in transition, leaving incarceration. So that's the possibility there, and that's the connection that needs to be made. It's not a matter of saying that, well, the community services just won't do it. It's not within their contracted relationship. And some of them now, including the Howard Center, are being very careful about limiting what they do and not undergoing expansion with the same amount of money that they have. So that's why this conversation is so critically important. So that maybe that some of the money that we're seeing from justice reinvestment can be put in a single place through a grants process that says, now you're going to be working with folks who have co-occurring disorders, substance use disorder, mental health disorders, and this is your responsibility. That's where we're trying to get. I think what we need is legislation that will do that, and I intend to, or I thought about introducing that legislation, but it's not simple. I mean, it's totally not simple. You've got all the departments having to work together, all the community partners needing to respond to the need and understand what it is. And then it doesn't let public safety off the hook either. So, I mean, it's just, it's big, but it's so critically important right now. I think it could lower the numbers that we're seeing that are going, in recidivism. Just my thought.
Can I go there?
Yeah, please. Well, just something, I mean, one of the things that I had prepared today is to do a primer on how justice reinvestment funding works, which is because it's extremely complicated. But basically it's a grant-based system, and it's flows through three people or agencies primarily: AGO, DOC, DCF. And it's all grant based, but again, what we consider justice reinvestment. There are a lot of things that are brought into that world that we call justice reinvestment that technically aren't a part of it, but are part of the whole restorative approach to justice. That many state agencies have different initiatives on. So just to kind of give a little bit of context, and I can speak more to that, you know, if Madam Chair feels it's appropriate.
So I heard you and I heard this. So what this vice chair was saying, can you give us that update this afternoon?
Sure.
And I said, sure, at the 2:30, because we've already talked about post adjudication work. Got it.
So a couple things. I mean, the Act 40 was repealed because it ended up that all they were really doing was figuring out the priorities for whatever justice investment money there was. And it's my understanding, I could be corrected, that there aren't any additional savings to be reinvested. We're going the wrong way as far as filling up the beds in DOC. So I don't know if it should be called justice reinvestment. I mean, it's very important for us to figure out how best to use our criminal justice and money. But it's not, we can't fool ourselves that we're making savings that we're going to be dispersing from justice investment.
And those savings came from initially, those savings came from our out-of-state beds, because it's always projected when we put together our next fiscal year budget, how many out-of-state beds are we going to need? So DOC could come in and say, we need I'm just pulling this out. We need 200 beds. And that's what the Appropriations Committee puts DOC's budgets for 200 beds. At the end of that fiscal year, maybe we only used 120 beds. So there was a bed savings there of 75 beds. And it was those dollars that were to be invested, justice reinvestment. Those dollars were to be invested back into the community to provide these services. Well, that all worked really well and good the first few years, because we would have a couple 100,000. One time we had over 1 million, because the estimate was we'd need a lot more beds out of state than what actually happened. Well, then we had a big savings in bed costs for that 1 year. But then it's like, hey, we're not going to put aside this many beds. We're going to cut that back. So you're not going to have all those savings years out. So that's why now we have put aside, there was an agreement made this past session, I believe, Trevor, help me here, that going forward, there'd be 900,000 put aside for these initiatives for justice reinvestment.
Yeah, that was a couple of years ago. And over the course of a couple of years, particularly Senate Judiciary, there were some commitments made to take some of that money into base funding, and basically it went away. That's a short story. I mean, it's there, but it's already, it's allocated, committed for something. It's committed to base fund. So there's no money available.
It's 900,000 continuous to the base, right?
Various programs.
Yeah.
Some important programs. It's,
We're gonna get an update on that this afternoon.
Well, of what the general structure was.
Yes, that would be
and
great.
Maybe not what the current status is. I
Maybe
don't know what so.
we go back to the general structure, but not tie it in so much to the justice reinvestment dollars.
Yeah.
Because that's where it was really tied into. Other questions? Before we take lunch here? Thoughts from Ellen or David, anything? This has been very helpful. I appreciate you taking the time.
Anytime, we won't keep you from lunch, so. In between.
Thank you both. We really appreciate you coming in.
You're welcome.
Thank
We always
you.
appreciate the opportunity.
Anytime.
Take care.
Bye-bye.
So let's take a quick lunch. We always go into lunchtime. Let's come back at 1 o'clock and we have a full afternoon.
I'm gonna do lunch at 2:30, my break, that's not fun.
So this afternoon, we're gonna be